just want to welcome everyone this morning. We're excited to see you again today and so glad that you got to participate yesterday if you did. And if you did not, then I'm happy to tell you that these sessions are being recorded and they will be available for you to watch at your leisure. But again, welcome back to the Tennessee Opioid Safety Planning Summit. This is day 2, and we have a wonderful agenda ahead today. Just again, thank you for being here yesterday and for your participation. Just wanted to share again some of the objectives of this conference, of this summit. We want to come together to understand our recent progress, trends, and gaps in addressing the opioid crisis. We want to share information about current and planned activities and successful approaches, which I'm excited that we'll be talking about a lot of these successful approaches this morning. We want to inform strategic planning processes by identifying strategic priorities, potential resources, and roles, and then also providing continuing education and training opportunity for health professionals. And we have some wonderful opportunities for that coming up this afternoon that you will not want to miss. And while yesterday, I think a lot of our thoughts for discussion that we talked about in our small groups were things such as, why is what we're doing important to me, and what do I hope to gain, and how can I contribute to this effort? Today, we're going to focus more on the promising approaches and successful strategies. And things that you can be thinking about during these sessions would include things like, what top 3 things should we continue or expand? Are there things that we should consider initiating to address unmet needs? And are there things that should be discontinued or changed because of low impact? So be thinking about those things that you may want to discuss in small groups, or write down your thoughts to share with us later, or in the feedback opportunities that you have. These are the important things that we want to address moving forward. So this morning, I'm so happy to get to introduce to you the first panel, which is made up of 3 ladies that I have had the pleasure of working with the last few years. And their impact on me has been nothing short of literally life-changing. And you will see why once you get to listen to them today. Their panel is going to focus on some treatment options and resources. And they have some exciting things to share. So I'm going to introduce them to you this morning and let them take over. They'll each have an opportunity to share with you for about 7 to 10 minutes. And then we will open it up for question and answer session. So first of all, I want to introduce Becky Haas. And Becky, if you could wave at everyone. She's on here with us. Now, Becky is an international presenter of trauma-informed care and adverse childhood experiences, or as we know them, ACEs study. And she's also a pioneer in successfully developing trauma-informed care communities. She developed trauma-informed policing training, which is certified in 2 states for officer in-service credit, and she's delivered it to the Oklahoma City Police Department, as well as in precincts within Tennessee, Virginia, North Carolina, and West Virginia. She has authored numerous articles in the global online publication ACEs Connection, and she co-authored a book, Building a Trauma-Informed Community and Toolkit for the Tennessee Department of Children's Services. She's also been published in Johns Hopkins Progress in Community Health Partnerships, Research, Education, and Action, and in the Annals of Behavioral Medicine. Becky also served as a trauma-informed administrator for a regional healthcare system, and she provided training, development, and delivery to the healthcare staff in multiple hospitals. And she was very instrumental in raising awareness of ACEs as a social determinant to poor health and addiction within rural Appalachia. Very important work. She has earned her professional certification in trauma and resilience from Florida State University and completed courses and a lot of other things. And Becky, I'm not going to read all of that. I want to refer you all to her bio because she has done so many impressive things. I would love for you all to read that. But Importantly, she serves as a consultant to ETSU and Ballot Health's Strong Brain Institute, and she also helped to pioneer the Northeast Tennessee ACEs connection. And Becky is one with her role in trauma-informed care who, again, has changed my life. And after I introduce these next two ladies, I want to explain that briefly. But the next lady I want to introduce is Andrea Clements, or Andy, Dr. Andrea Clements. We all call her Andy. She just waved. Andy, or Dr. Clements, she'll tell you to call her Andy, is a professor in the Department of Psychology at East Tennessee State University, where her main areas of research are religiosity, health, and trauma responsiveness, particularly focusing on addiction. She's developed, delivered, and studied trainings for varied audiences around trauma responsiveness, ACEs science, and resilience building for the past several years. And she's also currently collaborating with clergy and researchers from ETSU, University of Virginia, Duke University, and others around the world to investigate a theological neurobiological theory of addiction and treatment, which is really interesting. And she is testing church-based applications of that theory in the areas of transportation and housing. She's also co-founder and board president of Uplift Appalachia, which is a nonprofit focused on mobilizing local churches to provide intensive connection and physical, psychological, and spiritual support for people who live with addictions. She regularly mentors and teaches others to mentor people who live with addictions, including me. She's mentored me and made a huge difference in what I know about addiction and how to work with people. And then, of course, my next introduction is Anjali Murray. And Anjali, if you'll wave at everybody. Now, Anjali is a native of East Tennessee, and she currently serves as the Director of Corporate and Community Development for Revita Recovery Centers. Anjali has experience in organizational development and nonprofit management, and an additional 25 years of nationally ranked achievements in the fields of sales and marketing. She's excellent in that field. She has been recognized consistently for performance excellence and contributions in community development and service throughout the Appalachian Highlands and the entire state of Tennessee. And she was recently named as a 2021 Appalachian Regional Commission, or ARC, Leadership Fellow. So what I want to tell you about these ladies is that they are doers. They are not just sayers of what they are doing. They are absolutely doers. And they have taught me how to do some of these things that they're doing. My background is in marketing and sales and healthcare, and that's all boring. You can look me up on LinkedIn sometime if you need to know more about that. But the important thing to know about me is that I have lived experience with opioid addiction after a surgery and recovery. And after going through my experience, I knew I wanted to do something to help. And I just started going to meetings to try to learn more in my local community. And that's how I met Andy. And Andy hooked me up with a lot of people who were doing some wonderful things. And eventually I became the executive director of what we called the Holy Friendship Collaborative. And we were looking at ways to mobilize the church in our region to work with those in addiction. Because to me, faith is an important component of recovery. And you'll hear more about that, I think, from all three of these ladies. And Andy especially is doing a lot of research in that area. But one of the things that I learned from them in the education and awareness they provided for me through trauma-informed care and mental health first aid and just getting in there hands-on is that essentially your answer should possibly, and I heard this in a sermon not too long ago, why shouldn't we just assume that our answer should be yes when we're asked to do something, and then let the Lord tell us if it's not supposed to be? Andy has a saying that it's hard, but it's worth it. It's hard, but it's worth it. It's hard, but it's worth it. And it depends on how the day ends, which one of those you end on, but it is always worth it. And it is worth it to say yes when it comes to overcoming stigma of addiction and helping others. And these ladies do it well, and they've inspired me to. In fact, I took in a son we're adopting right now, who's 15 years old, who comes from a background of being an NAS baby and in a situation of addiction throughout his entire life with his family members. And it's been hard, but it's definitely worth it. So with that being said, I have rambled on too long. I want to turn it over right now to Becky Haas, and she's going to get started in telling us more about what she does. So Becky, take it away.
Well, thank you, Teronya, and it's great to be here today. I'm not going to use any slide minutes, but I'm going to kind of use it this afternoon for a couple hours where I'll be doing a training. So it's great to be part of this with Andy and Anjali, because we're all locals and we bump into each other and have each other at each other's events, and so it's good company, and many of the names on here I recognize as well. All right, so I was working for the Johnson City Police Department in 2014. My job there, I directed an $800,000 crime reduction grant to reduce drug-related and violent crime, and create a a probation program to reduce recidivism for felony offenders with addictions. And what happened in our programs, 35 agencies did together, and the design of the grant, yes, I'm in the best internet spot. Can you hear me? Am I breaking up? Well, I'll just plod along. The 35 agencies, the design of the grant was that we do it through a community conversation. So people came together around public safety and crime reduction that had not been traditionally invited to the conversation. And remember, it was drug related and violent crime. So we had community gardens, we had housing authority, art programs, mental health, physical health, corrections. Up with 2 awards. One was from the U.S. Department of Justice that I accepted on behalf of our group in 2014 from the National Criminal Justice Association. And very shortly after that, the chief of police asked me to write a grant for a family justice center to start a program under Governor Bill Haslam at the time had an initiative to raise up 10 family justice centers in the state of Tennessee, which is a best practice for addressing domestic violence. So chief had asked me to write a grant, and it was in that process with that grant that I went to California to the International Family Justice Center Conference and heard Dr. Folletti speak. And I had now been for 3 years working to reduce this drug-related and violent crime, spending time in the prisons, knowing the prison population, hearing the stories of children who are raised by parents who are heroin addicts. They're being violated regularly in the home by people that visit the home around the addiction. And now I hear about the Adverse Childhood Experiences study. And then 30 days later, I went to Florida with my probation program manager to a probation and corrections and addiction conference. And I met Dr. Joan Galise, who at the time, she was the director of the SAMHSA-funded National Center for Trauma-Informed Care. So within 30 days, I felt like I kind of had the wind knocked out of me in a sense, in that as high up as being at the U.S. Department of Justice, winning this award, why was no one talking about the upstream approach of trauma as a significant risk factor, not a small risk factor, a significant risk factor to addiction? And at the time in 2014, SAMHSA had a concept paper that you should use a public health approach to reducing approach. So that's when I intersected with my good friend Andrea Clements at ETSU Psychology, and we set out to train our town. Now, she is a tenured faculty, a researcher, publisher. I'm running.
Hey, can you hear me? You are still breaking up. And
Yeah.
Cassie tells me that you might want to try turning off your camera and see that might help your audio
Okay.
connection. So let's try that. I'm sorry. We want to see you, but
No. That's fine. It shows that it's going well from here.
it's breaking up a little.
Okay, hold on. I'm trying to shut the camera off. About a month ago, we just bumped up to business internet at the house, and it's not supposed to do this.
Okay. Sometimes the weather affects these things too, and we're having a cloudy, rainy day in East Tennessee. If you click on your picture.
Teronya, I was able to turn her camera off.
Okay, good.
So she should be able to talk now without problem.
Okay, go ahead, Becky.
Can you hear me?
Yes, you're good. Thank you.
All right, can you hear me now?
Yes, we can hear you.
Okay. All right, well, all right, so I don't know if my camera's going to shut off or not.
We've lost your audio now, Becky. I'll tell you what, why don't I make
2015? Huh?
Are you there?
Yeah.
Okay, go ahead. Go ahead.
Can you hear me?
Yes.
Okay, I've plugged into Ethernet. I mean, it should be.
We can hear you now.
Okay. So Dr. Clements and I set out to deliver trainings in our community. And in 3 years, with still working our day job, we trained over 4,000 professionals. The same kind of thing. And they wrote us back and said they weren't aware of any organization doing that. And so we were able to tell our story. In 2018, we had 2 first ladies that came, and people from 20 states. And after that, I moved into healthcare. And Ballot Health now was recognizing that trauma is a social determinant of opioid addiction. And so the other part of the work is talking about how to recognize that we're serving trauma survivors in our health settings. And so the education that I share with medical providers and pharmacists and clinicians, practitioners, is understanding about the trauma of the people that when they come to your waiting room.
Can anyone hear Becky? No. Becky, we've lost you again. There we go.
It's like a technology nightmare. Okay. No one is traumatized in this presentation. Okay, so quickly, so I began to create education. Not only were we making a lot of noise that this should be looked at as a social determinant to health in rural Appalachia, but also providers need to understand about effective service delivery to trauma survivors. When you look at national statistics, it's 70% of women in treatment have high histories of trauma, high ACE scores, 65% of men in treatment, 92% of homeless individuals have high ACE scores, 94% of children in juvenile justice have high ACE scores. And so we need to recognize that about 70% of those that we serve in any kind of service delivery are trauma survivors. So when you think about a medical setting, what happens there? We come in an exam room, ask someone to undress, put on a hospital gown, turn off the lights. And so all those things could be very triggering to someone in a health setting. So the education that I provide to healthcare is really to learn some ways to better support trauma survivors, to look at them as a whole person and not just the wound or the injury that they're coming in to see you about, but to understand that that as trauma survivors, there's more of an effective service delivery. So my work's kind of been two-prong approach. One is raise awareness of this as a social determinant to health, and then the other is through education and skill building. And I do apologize for the snafu on the electronics.
That's okay. I think we appreciate you so much for sharing that with us. I'm sorry you had problems with the audio there, that there were problems. But I do want to encourage everyone that this afternoon, Becky is going to be delivering a training on trauma-informed care, and it is so worth it. And this is something that many people pay her big money for her to come and deliver it to their organizations, and rightfully so. It's definitely worth it. So if you can attend that this afternoon, I want to encourage you to do so. Thank you, Becky. And I'm going to turn it over to Dr. Clements now, Andy, and let you take it away.
Yeah, Andy is fine. And I can do a great transition from Becky to Andy, because the way I got into this a lot is because she did bring me on and we sort of hit the ground running, sounding the alarm about trauma and so forth. And a parallel to that, actually working through one of her programs, the High Risk, High Need Felony Offenders with Addictions program, I began mentoring folks who had struggled with addiction, had been incarcerated and so forth. And so that is where I set this life goal. I actually have two. One is to solve addiction and the other is to reform the criminal justice system. And so I'm kind of working on them in sequence right now, but both of them are near and dear to my heart, because I got to know the actual people who were living in this, which is what we want to encourage people to do. And so this, because I'm a Christian, and it's like, why not do what you know? And I'd already been doing religiosity and health research. And so I and several other people, it is not just me, decided that a good thing to begin to work toward is to equip the faith community to be the army to help wrap around people. I'm going to use all my buzzwords, wrap around people who are struggling with addictions and their families, and help to not just offer some alternatives, but also kind of parallel things going as they may be experiencing other kinds of treatment and recovery and so forth. Because we have science that shows over and over this support from others and this connection with others is so beneficial for people to get into treatment, to prevent drug problems to begin with, and also in their recovery. And I do want to briefly mention the layman's terms of the thing I put in my bio about the theory of connection. And I'm going to just very quickly say that, and anybody who is geeky enough to want to contact me afterwards, we can talk for hours. But one of the things that I'm studying right now is basically how we are physiologically built from conception to connect with people. You've probably heard about bonding at birth and things like that. Well, what happens in that is people bond with their mom, mom and baby. They both produce opioids in their own bodies. They have opioid receptors and they produce their own opioids. And what I think is happening through this traumatic upbringing or neglect or whatever in a household where there is substance use, or a person is absent from the home due to incarceration or whatever, those are ACEs. We know those are ACEs, but that may be physiologically causing those natural receptors to be empty. So when that person later uses a drug of some sort, and we know it's not just opioids that activate that, it's like, oh, there's that mother love I never had. And so it's like our bodies are geared to that. But then once that's hijacked by actual opioids, that's filling a need that probably was caused by our bodies not bonding with people like they were supposed to, and so forth. So what we as what I as a researcher and some of what we're doing in Uplift Appalachia, the organization that I helped to found, are doing is we're trying to see if we can create this intentional connection with other people to try to restart that natural system in our bodies where we can produce our own internal opioids and reduce that need for other opioids, if that makes sense. So that's the layman's term, but on the ground, what that looks like is we want to equip folks to create connections with people who are addicted to substances. And we know when someone is addicted to substances, they pull away from people, they isolate and so forth. And so they're not going to come in the church and say, hey, I need somebody to connect with me. It's just not going to happen. And so we need to equip folks so that they understand, yeah, that person's not going to want to bond with me to start with or have a relationship with me, but I can facilitate that through giving a ride or having a meal or chatting with somebody in a restaurant or whatever, and gradually build a connection with that person. And eventually, hopefully, there will build trust. All of those things that we try to teach through the trauma-informed care training, that it's like understanding their side and not being judgmental and reducing the stigma, but all along knowing that if we can help them build connections and bring them into a healthy community, that's going to be therapeutic, whether they're in other kinds of treatment or not, or they've been in treatment and now they're in recovery, whatever. The system at this point is not really in place. I mean, we have a lot of people in the area who are working on reentry of prison population, and it's like, okay, you're free, but where do you go? And if we have some open arm churches ready that already understand all of the biology and the science and the treatment options and whatever, they're going to be better able to smooth that transition, I guess, because we can hand somebody a resource list all day. We can hand somebody, here are the dangers of relapse all day, but most people are not ready to process that, or maybe so busy with day to day, I just need to survive sober another day, that's not where they are. And so if you have people trained, and that's what our organization, we were talking about mobilizing the church, that's what we have found is really needed, is kind of to be that liaison, to be a liaison between the faith community and the clinical community and the treatment community, the patients themselves, to facilitate some of that handoff and support back and forth and so forth. So that is what we work on. And we also, within that, have developed an actual faith-based trauma-informed care training. Teronya's trained to do that. There's some other people that are trained to do that, where it actually is taking that information, but integrating it with scriptural principles to help, because a lot of times the faith community is like, ooh, that's like some voodoo. I was like, at the beginning, I was like, is there science behind that? What is that? I wanted to know, is this really true? But to take that and we've integrated it with, here is how this is scripturally, based anyway, it aligns well. And what we want to do is do that with lots of things. It's like help the church to see, okay, these are treatment options, and here is how this does or does not, the pieces of it that do or do not align with your faith. And that's going to help the church to trust some of those things going on in treatment. And so you don't have one person saying, don't do that, and the other one saying, don't do that. We want the groups working together. And so we're trying to be a liaison between all of these folks. So does that kind of sum me up, Teronya? You know what I'm doing better than anybody, probably.
That is excellent. And all of those things that she's saying, you can see how the work that Becky's doing, the work that Andy is doing, they intermingle and they go so well together and they build upon each other. And the whole trauma-informed care piece, it's seeing everyone, every individual that you come in contact with through that different lens, that trauma-informed lens. And it does affect how you treat them and how you interact with them, how you provide services for them to help them through their problems. And as we go to Anjali next, she's going to talk a lot about that, I'm sure, and about how her work is involved with not only the medical aspect, but bringing in those wraparound services to that medical care. So Anjali, I want to let you take over from here, and then we'll end up with some questions. So everybody be thinking of your questions that you want to ask. Anjali?
Thank you. I was so glad to hear Becky and Andy both. Both of them have been great friends and partners over many years, and I just appreciate them so very much. And Teronya, you have been just wonderful, and I see a lot of other friends on here today, and I want to thank you all for having me. And what I'm going to talk about is in the medication assisted treatment field, how to build corporate and community partnerships that do these same things. You know, what they were talking about was, you know, ACEs and trauma informed care, but, you know, you have to have good community partnerships in order to really get your patients the care that they need. And what I'll be talking about also will lead into the next segment, which Jason Pritchard and his team are doing some wonderful work with this as well. So I think it'll be a good transition into the next segment. So we'll just go ahead and get started. So next slide. Again, I want to thank Lisa and the One Tennessee staff, and of course, all of y'all for being here today. And my topic is going to be successful approaches in building corporate and community partners and why they matter. And I could sit here and talk about medication assisted treatment, but you know what? All y'all know what that is. And for a lot of partners and community agencies, it's a taboo subject. It's not well received a lot of times. And so we have to go out into the community and explain and educate what MAT is. We have to show and be very transparent and be willing to coordinate services and be willing to be open and honest about everything that we do. So I want to share with you what we do and why and how that's been successful for us. Next. Okay, first of all, I want to share with you some of the things and the agencies that I've worked with. And those include social services, law enforcement and criminal justice systems, educational institutions, healthcare, labor and workforce development, faith-based organizations and leadership, civic organizations, and of course, media and press. And when you have good relationships with all of those, then you can really get a lot of things done. You can get your mission out and you can get your information out to just about everybody that you need to. And so my work with Revita over the past 4 years has been to develop those partnerships all the way from Whitfield, Virginia, which is where we start, all the way to Knoxville, Tennessee, and to build those partnerships so that, number one, our patients get good service and good treatment when they leave our office. And in medication assisted treatment, your patients are coming in there either weekly or biweekly or monthly, and they only see the MAT provider and the clinical team there, you know, very little. I mean, it's once a week or twice a week or once a month. But when they leave our office, there's a whole world out there that they're exposed to, and we have to have partners for them to go out there and get their extra services. If we don't have those partnerships set up, then they're on their own the minute that they leave our office. And that's so very important. That's why building these partnerships and great relationships and collaborations are super important. Next. So what are the most important things in building partner relationships? And I identified, I think, 5 that I wanted to share with you today. And the first one is being visible in the communities that you serve. And I don't know how many of you that are on here today work in treatment, and especially MAT treatment, but being visible everywhere is super, super important. Every Tom, Dick, and Harry thing that you can go to and say, look, here we are, you know, ask us questions, be willing to be vulnerable and let someone ask you anything that they want to ask. You know, go to everything and put your information out there for the community to see. You know, years ago, a lot of treatment centers, they didn't want to go to many things because they were not welcomed. But I think showing up and being willing to say, here we are, we want to be partners with you is very important. Number 2, be a team player, and if possible, be the leader of the team. And one of the ways that we do that is we take part in almost everything. And one way that we became a leader over the past couple of years is in our Withville area. We established an opioid task force, and we allowed our office there to be used on a day that we didn't have services there. And we had a lunch meeting once a month, and we had every single organization that would come join forces with us and create an opioid task force. And that's a picture you can see there. We had everything from someone from the local hospital that was there, the health department, the police department, fire department, and all your social service agencies. Someone from every single thing was there just about. And so we worked together to see what was needed. Where were the gaps there in the Bland counties? Where were the gaps, and how could we work together to address those? Well, guess what? We held it there in our office. So all of those agencies were coming into our office and seeing what we did. Of course, it was on a day we didn't have patients because we couldn't have them around patients, but they saw our office. They were there looking, wall to wall, eyeball to eyeball. Our other staff was there. And it was great because we were being visible. We were saying, hey, here we are. Ask us questions, and we want to be part of this community. Next. Be transparent. Encourage questions, like I just said, and answer questions without being on the defense. And a lot of times, people or agencies that are MAT are always on the defense because they've been used to being hounded and treated like the redheaded stepchildren for so long. And so we're trying to reduce stigma. And so instead, have a we mentality and invite the community to be part of we. Have a we mentality. We're all in this, we're just like with COVID, we're all in this together. Everybody is a part of. Substance use disorder, opioid use disorder. This is not a me or a you problem. It's a we problem. And the next thing is super important, be accepting and complimentary of other forms of recovery models. Medication-assisted treatment is not the only way to recovery. And so we are very open and honest and say, this is not the only way, and MAT is not appropriate for every person. So we invite other forms of treatment models to come and partner with us, because if we have a patient that this treatment doesn't work for or is not appropriate for, we want to have a partner to refer them back out to that works for them, and vice versa. Next is invite to serve. Oh, I'm sorry, go back. I wasn't finished. Thank you. I'm so sorry. Lastly, invite to serve. If applicable, offer partners the opportunity to share services with your patients. And we have things like lobby table services. All of the social service agencies, like this one is UT Extension, but the health department will come, and domestic violence services will come, and housing will come, and GED services, and then higher education. They will all come and they'll do a table in our offices, and they'll set up their services. And while our patients are sitting there waiting for their name to be called for, to go back and see the counselor, the case manager, or the doctor, guess what? They can use their time wisely and build relationships with the people at the table. And the people at the table are those people out in the community that they need to be seeing when they leave our office. Many times we find that it's very hard for them to go to the health department. They feel judged because of the medication that they're on. But guess what? If they know the people at the health department, because they see them in our office, they feel like, hey, I'm not being judged any longer. They're willing to come here. They're willing to come into an office where I'm receiving treatment and talk to me. And that breaks down so many walls. And it's so very important to let them see that. So also, the one that I think is probably the most important lobby service is domestic violence shelters. That one is probably the most important, is to have as many of those come in as possible, because a woman or man, because domestic violence can be either or, that may be the only time that they're by themselves that they could actually hook up with someone, from a domestic violence shelter. because they're monitored by their abuser so closely, and their phones and everything. So that has been a really important service to have in our lobby set up. Okay, now I'm ready for the next one. Okay. Building partnerships also begins with education, and everywhere you go, whether you're hosting an event or whether you are attending an event, educating about what opioid use disorder is, and that it is, there's 3 stages to get there: tolerance, then dependence, then the actual active addiction. And I won't read all of that because I'm sure all of y'all know that, but making sure that who you're working with does know that, you just don't become addicted. There's stages of that. Okay, next. And also building communities continues by reducing stigma, and reducing stigma is reduced greatly in our communities by the words that we use. And when they send this out, or I guess they'll send it out, this document here is, it's called Words Matter, and it has all sorts of different words on there that we need to adopt as a community and start using. And these words do change, words change and verbiage changes, and we progress in how we address substance use disorder all the time, and the things that are most appropriate to say. But the word habit, the word abuse, the word opioid replacement, those are words that we don't want to say because they contain a negative connotation. They're ugly words, just like urine drug screen. We don't want to say that. We want to say drug screen analysis. The word urine is just not a real pretty word. There's a lot of words like that we need to change how we say things out in the community, and it will change how people look at this disease. Next. Okay, if you are a treatment center or any type of agency actually that works with people that are working to get into recovery, share your impact reports if you have them. That is so very important to show your community. And so this is something that it's very powerful to show what's going on in your agency and how your treatment works, regardless what type of treatment that you offer. Show that. And I think the most powerful statistic is this one that I highlighted in hot pink. Statistically, each patient that's is connected to 7 others, and each patient in treatment is closely connected to 7 others. And so that way you can tie that to how many people your treatment is actually affecting. And so this actually shows our Morristown office, and it said we had 157 new patients in Morristown this past year. So if you times 157 times 7, because those 157 patients directly impact 7 others, that's 1,099 lives that were impacted positively because those people were receiving treatment. So I'll say that again: every person that receives treatment impacts another 7 lives in a positive way. So company-wide, you can see there, my little arrow says we had 17,500 lives that were impacted because of people receiving treatment. So that's a pretty powerful to be able to share something like that. So I encourage you at your office to do that, or your organization, whatever type of thing that you're offering. Sharing impact reports is really great in order to get the word out in your community and reduce stigma. Okay, next. And lastly, offering services to your partners and your community members. One of the things that we do is we offer 3 main things. Every time I go to speak, I'll say, okay, the number one thing I want to do is offer 3 things to you guys. One is a resource. May we offer you and your staff resources for safe prescription drug medication storage. And so I talk about prescription drug lock boxes and how those work. Then the next thing is training and education. May we offer you and your staff an educational training on the signs of prescription drug misuse, and then treatment options. And then lastly, private help. We want to invite you and your staff members to call our toll-free number and get confidential help. And so this is really important when you are at the Rotary Club or when you're at the Chamber of Commerce or when you're talking to any type of a group, that you are offering things to your community, that they see that you're not just serving the patients that come to you, but you're also offering things to your community. And that's really important. Next. So I'll close by just sharing my contact information. This is my email and my mobile number. Our website, revitarecovery.com, and we have a toll-free number for all of our locations, which is 844-739-4122. We're also on LinkedIn, Twitter, and Facebook. We have 7 different location pages for Facebook, but I know this will be sent out. Anybody's welcome to ask me questions. And then the last slide is just to thank you all for being here today and for being interested in what treatment is about and what treatment centers do. We really appreciate you, and I hope you found this to be informative. So thank you.
Thank you, Anjali. So I want to take this opportunity to just say, you can see how the treatment of an individual is, we've got to treat the whole person. There are so many facets to each individual that are important, not just in what we prescribe to them for their treatment, but also their well-being and their overall health, mental, physically, emotionally, spiritually. All of these things are important to be treated. And that does include their beliefs and their faith. And in your practice, understanding that and asking those questions about that, what is important to you? And as we're talking about this and we see things through that trauma-informed lens in treating our patients, we will recognize that, we'll understand the importance of connections and making sure that our patients have those connections with people in their lives that are important to them, or possibly breaking connections with those that are toxic to them, or eliminating those connections for a time. But just being able to help them navigate those waters through recovery is important in your clinical practice. And so I want to open this up to questions. If anybody has a question, just unmute yourself and I will try to recognize you, or just wave your hand. I see Lisa. Go ahead, Lisa.
I just wondered, Anjali, do y'all use telehealth services in providing services to folks?
We do. And before COVID, we did not have telehealth services at all. We had nothing. And as soon as COVID hit and everything shut down, on a Friday, we had no telehealth. And on a Monday, we were fully telehealth with, it was like, whoo, in 7 locations. It was a major undertaking, and we had to get everyone trained on telehealth. And it was like everyone worked 24/7 just about for 2 solid days. But we did. And the thing I'm most proud about with that is that, as you all know, living in rural Appalachia, so many of our patients either didn't have internet or didn't have secured internet or viable internet that would stay on long enough to support a telehealth visit. So what we did and still do, we just opened back up to face-to-face visits this month. But from March of last year all the way until just this past month, we saw all of our patients via telehealth, except those that were pregnant, except those that, of course, those that had, when you had to have a drug screen, you had to come in for that part. But everyone that did not have, and of course, your induction, you had to come in face-to-face. But after that, everyone did telehealth visits, but we kept every office was still open for those that did not have secure internet, did not have viable internet, they had sketchy internet, whatever. And we kept every office open with enough staff there to keep it open, and had a special room that stayed clean between people where they could use our computer and our internet to telehealth with their provider. Now, there were some times when their provider was there in the office, but just in a different room, and they were telehealthing with their provider in a different room. Other times the provider would be at, at their home or whatever. But, and sometimes the nurse would be there, in a different room, and the case manager would be in a different room, and the counselor would be in a different room. And other times, all three of their providers would be off site, but the patient would be there at our office using our telehealth room. And that was so important because not one patient, it was our goal that not one patient was left behind, that not one patient did not get treatment because of that reason. If it was for another reason, that we couldn't control, that was that. But we could control this. We could provide that for them, and we did.
That's great. Thank you.
Are there any other questions? Anybody? Just wave at me. Hi, Richard. I'll unmute you. There you go. Oh, there you go.
Yes, Anjali, I appreciate what you were sharing about my former hometown of Morristown, because as you know, there's a lot of misinformation out there about the value of an MAT clinic. And I think that's a story that reflects well on Revita, that y'all worked to have that clinic open, because for a while there, they didn't want that clinic there. And so you want to share any more about the challenges that communities may have in terms of opening a MAT clinic?
Well, it's always challenging, especially in Upper East Tennessee. You would think right here, where the greatest problems are, that there would be the greatest support, but it's just education. And there's been so many bad players, and I've known a lot of them, and I've even worked for some of them. But there's been so many bad actors and bad players in the game, so to speak, that the community is just gun shy of medication assisted treatment. And I can understand why. I can totally understand why, and I can totally understand how that's happened. So, but the other part is just the lack of education on how it works and why it's useful. And I think that one of the biggest things is, of course, like I was sharing in my presentation, as someone that works in community development, sharing that there's lots of different types of treatment, and there's never one type that's just there's not one type that fits everybody. And what we do certainly does not fit everybody. And I think that's very important to share when you do a presentation or go out in the public, so that they know that you are in agreement that this is not for everyone, because it's not the, just like all medications, there's not a perfect medication for everybody's heart problems or everybody's diabetes. There's not one perfect type of this, or not one perfect type of depression medication. Everybody needs something different. And some people don't need medication at all. They need total abstinence and just counseling. It's just based on the person. We're all not made and built the same. But there in Morristown, we did have some issues there, and they were overcome. And we ended up last year winning the Small Business Healthcare Award with the Morristown Chamber of Commerce. So it's like, oh my gosh, really, after all that. And then this year we're up for the overall Small Business of the Year, and also the Horizon Award, which is for small businesses, which is a small business that's been in business less than 5 years. So we'll know next week is the presentation of the award. So, if we get it or not, that's here or there. We're just glad to be nominated and thankful for that.
That's an incredible success story right there. And that also speaks to Anjali herself and the work that she does, making connections in the communities where she works. And I have seen that firsthand. She goes in like a whirlwind and meets everyone. And it's just her attitude and her presence and the way that she sees people, the way that she sees individuals and who they are, and where they come from and the lenses that they're looking at their life and their recovery through that makes a difference. And she brings everyone together. And I would just like to ask the question and also get Andy and Becky to chime in. We're seeing the importance of practices, medical practices, and how they get involved in their communities and get involved with the wraparound services available and educate communities, which is what Anjali has done. And also I know Becky has done a lot of work in Jefferson County, Morristown, and Andy to educate communities on trauma-informed care and how to see through this different lens of what is happening in their communities. And that makes a big difference. So how can clinicians bring this into their practice, and how can they get the training, and what's the process for bringing that into their practice?
Okay, well, I'll chime in. I was at Ballot Health for 18 months, and I know that Ballot is fully committed to using ACEs, education, trauma-informed care as raising awareness, treating it as a social determinant to health in rural Appalachia. So I know since I've left there, they do have training that they're providing in the community to schools, and I believe in their healthcare staff. I'm still doing training here in the area as an independent consultant. And one of the hospitals that they have in Greenville, when the merger happened, they have 2 hospitals there, and they're opening a program called Strong Futures, which will be women and mothers 18 over with children or pregnant with addiction. And they see that it's going to take a 12 to 24 month, and not just the treatment piece, but also how it's like Dr. Nadine Burke-Harris, the Surgeon General of the state of California, and very well known around the trauma. She said she realized as a pediatrician in San Francisco that she could, through her practice, help people live with the symptoms of lead poisoning and be comfortable and give them literature, or she could go to the house and find the lead. And so the Strong Futures program, that's what they're wanting to do. Is many of the people, Anjali and Andy, we've seen this in these small rural communities. You come out of jail and you go right back in the setting where you were when you used drugs or you sold drugs and you went into incarceration. So how can we change up? How can we reduce the lead at the house, the sources of toxic stress, getting kids in Boys and Girls Club, finding transportation, getting you involved in parenting classes, life skill classes, and those wraparound things. So I'm super excited about the progress that I see here. People certainly can visit my website, beckyhaas.com, and reach out about training. The Strong Brain Institute that Andy and I are on, we just in December filmed a first certificate program that's going to be released soon, that people can go online and register at ETSU and take 4 hours on basic trauma and resilience. And there's going to be a lot more programs coming in that respect to help train professionals down the road.
Thank you. And Andy, if you would speak to the involvement of churches and how they can get involved clinically as well and work within clinical practices as well.
Right. One of the things that we would like to do is help both the clinical community realize that the churches can be a resource for lots of things. I mean, the transportation is one that we've worked most on, but being able to have, like I say, a volunteer army out there that can support people in their recovery. But I think some of that's going to take interpreting the science of it and the medicine part of it to the faith community. And I would love to get some folks who are interested in creating those connections together, and maybe bring clinicians into a faith community training, or even bring, well, I guess we are kind of the faith community, to some of the clinical practices to say, here are things that could be partnerships that could be facilitated that could really help support your patients. Because I know particularly physicians are frustrated with, I've got 12 minutes or whatever to see this patient, but if I can trustworthily hand them off to these folks that know what I'm prescribing and know how their treatment works, and help to kind of be that ongoing voice that supports that would be so helpful. I know for any kind, I mean, that could be for any kind of disease. You know, did you take your blood pressure medicine this morning, or did you get to your recovery meeting? I mean, they're very similar, but I think a lot of times we're siloed and we don't capitalize on that strength. And we would like to serve as that liaison. So
Excellent. So are there any other questions? I think we've got just a minute to give anybody an opportunity to ask a question right now. I'm looking and I don't see any more at this point. So it is 11:02. What we will do is I'll encourage you to take a 5-minute break. We'll come back at 11:08. That's what we'll do. And at 11:08, we'll begin the next session with Jason and Josh and Glenn. And I'll introduce them to you briefly and let them take over. And we will take it from there. They will be talking about more of the integration of services and coordinating that in your community and in your practice. So thank you, ladies, so much. I hope that if you have a chance to stick around, there may be more questions at the end for all of you, if you can. And again, I want to encourage you to attend their other sessions. Becky will be leading a trauma-informed care training this afternoon. So if you'll just stay in here with us, you can mute yourself, you can take yourself off camera. I will come back on and call you back when it's time to get started. So thank you all. So we're counting down to about 30 seconds here before we get started. And I want to invite you to come back. And if you're with us, if you would like to ask questions again at the end of the time that they speak, I want you to just unmute or wave your hands at me and I will recognize you for questions. So here we go. It's 11:08 and we're going to get started now. So I want to welcome you back. This is our second session this morning, our second panel, and we're going to talk a little bit here about successful integration and coordination of services. And I want to take a moment to introduce our speakers on this panel. We have Jason Pritchard from Ballot Health, and I have known Jason for a few years, so it is my pleasure to welcome him here. Jason, I just want to say, if you want to meet somebody who is enthusiastic about what they do and about everything they bring to the table in this field, it's Jason. And so I know you'll enjoy hearing him talk. But Jason Pritchard is the Recovery Program Manager operating under a diverse stream of grants from the Ballot Health Department of Population Health. And Jason has a bachelor's degree in finance from Virginia Tech. And this is something really important and interesting about Jason, is that he spent 16 years in active addiction, and he has now been in recovery for the past 9 years. Yay. Jason is also a certified peer recovery specialist for both Virginia and Tennessee, and he uses his life experience to help others in the pursuit of living a drug-free life and as productive members of society, which he has certainly become. Jason is certified to train and supervise peer recovery specialists for Virginia Department of Behavioral Health and Developmental Services. He became an ordained minister in March of 2020. Jason spent 5 years in incarceration, and now he has a heart for people who are battling the bondage of addiction. In 2018, he was recognized by the Virginia CARES program, who awarded him the Cindy Martin Special Achievement Award for those who excel in society after being incarcerated. Jason has collaborated with community organizations in Southwest Virginia, such as Highlands Community Services, ASAC, Hands and Feet Ministries, and Tri-Cities Recovery to bring awareness of the opioid epidemic to the community. His role currently at Ballot Health is to engage those existing organic grassroots coalitions and the faith-based community in order to overcome the opioid epidemic that ravages Southwest Virginia and Northeast Tennessee. Jason was promoted to Recovery Program Manager. He manages Ballot's Peer Help Program, and he now manages a team of 6 peer recovery specialists serving both Tennessee and Virginia. He was one of 3 individuals that created a SARA, which is Substance Abuse and Addiction Recovery Alliance of Richmond in Virginia, and he now serves on their board of directors. He was also asked to join the board of directors for Red Legacy Recovery, that helps ladies in recovery in Carter County, Tennessee. And he was most recently voted to be on the board of directors for People's Incorporated, which is an organization that provides opportunities for economically disadvantaged people and helps them reach their goals and enhance their lives and their families and their communities. So thank you for being here, Jason. And before I turn it over to you, I also want to introduce Glenn Says. Did I say your last name correctly, Glenn Says? Yes. And Glenn is with the Upper Cumberland Human Resource Agency. He's the Director of Substance Abuse Solutions at the Upper Cumberland Human Resource Agency in Cookeville, Tennessee. He coordinates social services for people in treatment and recovery in the Upper Cumberland region. He has come out of retirement from his 21 years in the high-tech industry to contribute his expertise and passion in the war against the opioid epidemic. His expertise is in strategic management controls, specifically within manufacturing and planning operations and quality improvement. And he uses those same principles and similar tools, collaborating in manufacturing operations to help the public and nonprofit sectors work effectively together. His passion is to see the restoration of men and women who are having their lives affected by opioid and heroin use disorder. And this passion that he has is driven by the relationship that he has maintained with his 38-year-old son, who has been a heroin user for 14 years. So Glenn has lived intimately within this community for the last 5 years, and we're pleased that he is here to share his expertise with us today. Thank you, Glenn. And then finally, I want to introduce Josh Weil. Did I say that correctly? Weil?
It's Weil.
Weil, I'm so sorry. Josh
That's okay.
Weil, I'm sorry. Now, Josh is a regional opioid prevention specialist, or as we call them affectionately, ROPES, in Memphis, Tennessee. And he's with the Memphis Area Prevention Coalition, and he's also the chairman of the Prevention and Education Task Force for the Shelby County Health Department. Josh has also been involved in the Shelby County recovery community since 2001 and is in recovery for alcohol and opiate addiction. He received his Bachelor's of Science in Nursing from the University of Memphis in 2011 and is a registered nurse in the state of Tennessee. So he is here to talk to us about the ROPES and what their role is as well. And I'm going to turn it over now. Thank you for being here, all three of you. And I want to turn this over to Jason and let him tell you more about himself and what he does.
Can you hear me?
Yes.
Okay, so as she said, I'm Jason Pritchard and I oversee the Peer Help Program. And of course, a peer is a like-minded individual, but it's also an acronym of our services. So we do programming, employment, education, recovery, help. So we help people who are currently incarcerated or have a history of substance use disorder, and we can aid them in any of those 4 categories. And I think the things I want to talk about today is how peer support could be accessed or collaborated more across the different services. And for instance, like how can a clinician refer patients for these services? And in our service area, which is the upper 8 counties of Northeast Tennessee, plus Hamlin and Koch, they can call our peer helpline, which I'm going to put the website and the phone number in there as soon as I am finished. But outside of our service area, they can also call the Tennessee Red Line, and I'll put that number in the chat box as well. And then the way our program came about is we have an array of funding sources. Like the program has really been on fire. The primary reason is not only is it a peer help program, but it's also a second chance employment program in its own. We currently have 6 peer recovery specialists that have over 20 years of incarceration time between the 6. So Ballot has kind of stepped up and set a standard as far as giving people a second chance and hiring despite felony backgrounds. And we're really seeing benefits. And so our funding comes from federal, state, and foundation providers. We have a $1 million HRSA grant, which employs 3 of our peer recovery specialists. We were recently contracted by First Tennessee Development District to take our peer help model to 2 Tennessee county jails. We engage with individuals 90 days before they're released, and then we navigate them to different services that addresses the full continuum of care. For instance, they might need clothing, housing, food, transportation, and then the overall goal is gainful employment. We also have received a $200,000 contract from the Virginia side to do peer recovery expansion. And that's to train 72 peer recovery specialists over the next 3 years. And the unique part of our program is that currently we offer the individuals, because Ballot is located in both states, we train them through the Virginia curriculum, which is an ICRC certification, and they have to have 500 contact hours in order to work with or 500 contact hours working with individuals who have a history of substance use disorder and mental health. We provide them access to those opportunities. And then once they're certified, Tennessee has a reciprocity state to state certification process. And so when they receive their Virginia certification, they then engage with the Tennessee Department of Mental Health and Substance Abuse Services, and that is reciprocated. So that's something that's really unique. So the peer recovery specialists on our team are all dual state certified. I think if I'm looking at the questions here, are there any gaps? I'm going to just reiterate something that's probably been said many times in many conversations. The two biggest gaps we see, number one is transitional housing. We're actually working to pull together a work group. The one resource that is available is the Oxford House, but you also have the gap of the amount of money it takes for a person to enter the Oxford House program, which is about $270, and coming right out of incarceration to have, or treatment, to have that kind of money up front, it is a big barrier. But we're pulling together a work group with the United Ways of Southwest Virginia and Northeast Tennessee to see if we can pursue some funding that would provide access to transitional housing for individuals coming out. The next barrier or gap is not so easily addressed, and we all know is transportation. We've received calls on a daily basis to our peer help warm line asking for transportation services. Sometimes we're able to oblige, sometimes we're not. Some of our funding specifically has to be spent in rural counties. In Tennessee, of our 10 service area counties, only 6 of them are considered rural. So it does limit the services that we can provide in some areas, but transportation and housing has been the two biggest things that we've had problems finding. And I want to say this about peer support. Peer support is an evidence-based practice. It improves the quality of life. It increases and improves engagement with services, meaning navigation services. So if I have a person that's working with me that guides me to a service, makes sure I go, if possible, gets me there, then I'm more apt to pursue the service. And by pursuing the service, it's going to increase my whole health and self-management. And peer support acts as a bridge from clinical services to community-based wraparound services, which can then address the full continuum of care. So we're not just talking about using a peer recovery specialist to address treatment or substance use, but we're addressing the underlying health conditions too, that may not be necessarily mental health. It could be a consequence of the substance use or the mental health challenge. It might be endocarditis. It might be hepatitis C. It might be HIV. But the peer recovery specialist is able to identify services that are available and navigate the individuals too. And it doesn't always mean that they're navigating them to sobriety or recovery. Sometimes it might just be there to hold their hand when they're not ready to enter recovery, so that the day they know who to call. So I think that's a good overview of what peer support is and who peer support specialists are. As far as like how they can be utilized by clinicians, we know that they're already being used like with Frontier Health and mental health. But I think a new component is that peer recovery specialists can also be used as navigators. Many times they've used resources themselves that the clinicians may not be aware of. And so to engage the peer support specialist of different community, grassroots, faith-based services that are available, they can make that connection.
Excellent. I think the work that you have done in this field, Jason, is nothing short of miraculous in our region, and actually everything about you, I look at your life as one miracle after another, and the work that you do is just boundless, and you're so energetic in it, and what you've done to establish this peer support network is incredible, and it's something that I can definitely see being used by every clinical practice out there. They should have access to peer support and be able to provide that service for their patients. So thank you for sharing that, Jason. Appreciate it. And we'll open up for questions for him in just a few minutes. And at this point, I'd like to go ahead and turn it over to Glenn. I believe I have you next. So Glenn Says is going to speak to us about the work that he does.
Thank you, Teronya. And thank you, Lisa and One Tennessee, for inviting me to come in today and for putting this marvelous group together. If you were not in the first panel discussion, go back and watch the videos that may have been recorded on that. There were some marvelous things there from Dr. Andy and from Becky and from Anjali. And so thank you for letting me be here today. My whole passion of seeing things done correctly and in order and effectively. I've never been a part of a nonprofit or a governmental agency. I've been an entrepreneur all my life, owning and running my own businesses most of that time. Almost my whole career was in the high-tech computer industry, putting in large mainframe style computers that were, I'm starting my clock here so that I don't go too much over time, putting in computer systems that would manage manufacturing companies. If you've got 10,000 parts coming into 5 different manufacturing facilities and 700 employees putting those parts together to get a finished product, how do you do the just-in-time delivery of those parts, the quality assurance of getting those parts put together correctly, the price points of getting everything within a budget so that you end up delivering a product to your consumer that works, is reliable, that will get good reviews, and is out there as a good finished product. So that was my whole career with working with manufacturing companies. Now, like Teronya mentioned, I have a son who was a professional snowboarder. And now professional snowboarding is a real job in the Seattle, Washington area. He was involved in a major accident. They took him off the hill, put a 9-inch titanium rod in his arm, gave him his first 90-day prescription of Oxycontin, and then his second 90-day prescription of Oxycontin. So a year later, my son, who was a leader in his high school, leader in his church youth group, 2 years finished with college, is now living homeless as a heroin user on the streets of Seattle. That continued for the next 12 years. And if you want to hear the ending of the story, then you'll have to come to my what are they calling it? Lunch and learn session between 11 and 12. And I'll give you the end of the story there. It's a good ending. So my frustration was, if we can build lawnmowers, if we can build radios, if we can build cars with precision and with a logistics plan, why cannot we take an individual? Why are there so many gaps in the system? Why do we get a person started in their road to recovery and then they fail, they relapse, they lapse, they relapse, you have to start all over again? Why? And now I understand that part of this is the natural inherent function of an addiction. It is not just always a one fix, but why do we keep losing the people within the process? So I came out of retirement about 5 years ago and began looking at this and trying to find a solution for a true continuum of care. Best illustration I can give you of this is, have you been on any of the really back road mountain roads here in Tennessee? My wife and I just moved here 3.5 years ago, and we love to explore. And we got ourselves on one road. We knew we were here and we needed to get here, but we lost our GPS, and we said, well, if we just keep going west, or east at that point. We'll eventually get to that place. Well, the road kept getting smaller and narrower and turned into a gravel road. We were going up this hill and the gravel road finally gullied out. And I was afraid I was not even going to be able to turn my car around and get back out, much less get to the solution that I was looking for, that next town over, because there were holes in the system. There were gaps in the system. I couldn't get there without losing my axle, without bending a rim, without tearing out the oil pan of my car. We lacked a continuum of care, so to speak. So that's what I am looking at addressing. What I moved to Tennessee under the invitation of the executive director of the Human Resources Agency and the Development District here in Middleton and Upper Cumberland to come up with a solution. What we have put into place here over the last, well, it's actually been 10 months that we have been in action. We got a grant from the Bureau of Judicial Assistance through the Department of Justice to implement this system. So we're a brand new system that just became active in July. But we have created a hub and spoke system here for the Upper Cumberland. Now, everybody, if you are looking at the history of treatment and recovery services, you are familiar that Vermont started the hub and spoke system and were terrifically successful in implementing this in Vermont. And it's been very successful in other parts of the country. I saw the problem with most of the hub and spokes was that the hub was almost always a treatment center. Now, my premise that I brought into this was that if your hub is a treatment center, then they have a vested interest in keeping the clients connected to that hub. Now, they may go out for services of housing and legal services and transportation and medical services outside of their treatment, but they have a vested interest in any referrals being kept with that treatment program. And no offense to the treatment programs, I love you guys, but I think the hub needs to be an objective organization that is not tied to any specific treatment program. It truly needs to be no wrong door policy with your hub. They're going to bring people into the system and they are going to connect that person in need to the most available, best, first available treatment program. We have been doing this now since July. We have had 365 people come into our program that have registered. We've done intake, assessments, and placement of some sort of 365 people. Now, those 365, we have approximately 60 of them that we have placed into treatment programs. That's both residential and MAT clinics for getting that first step, that clarity of mind step, getting the drugs under control within their system. So over 60 places we've sent people, and of the 60, there's 18 different treatment programs that we've placed into. So we're not tied to just one treatment program. Once the person comes out of the treatment program, we take their recovery coordinator. We have 3 recovery coordinators right now within our system. All of them are certified peer recovery specialists. Between the 3 of them, they have over 50 years of lived experience and about 40 years of recovery experience. So I've got the real dream team of recovery coordinators here working with us. Once the person is coming out of treatment, we work with them for the next step. My philosophy is our hub is not providing any of the treatment, any of the services ourselves, unless we have to. We are simply traffic directors. Imagine the meme or video of the, I think the Philippines has the best one. The traffic cop that's in the middle of the intersection, there's 6 or 7 roads coming in, they're dancing around, stop here, you come here, and they're dancing there, handling all the traffic coming through this busy intersection. I consider our staff to be working in the busiest intersection in the Upper Cumberland. the flow of people needing services and getting them directed to the services that they need. We've placed people, like I said, in over 60 different treatment programs since we started. I explained that if we were selling hot dogs, we would be rich right now. Unfortunately, that's not what we're doing. We're treating people with the most serious consequences that I can think about. We love what we're doing. We would love to see this replicated. We've got the attention of the governor's office of what we're doing here in Middle Tennessee. We've got the attention of the Department of Mental Health and Substance Abuse, and they are looking at us as a possible model for doing this. Use the structure that you probably already have within your region. The Human Resources Department, the Development District. I'm working very closely with both of those agencies to get out into the 14 county area that we serve. Our objective is to get people clarity of mind, that's the treatment part, plus stability of environment. That's the housing, the job, the transportation, the legal issues. So clarity of mind, stability of environment, to give them the opportunity of them discovering their purpose in life. I would love to answer more questions for you. Come to our lunch and learn session, and you'll see I have a couple of graphics, and I'll also give you the ending of the story of my son, Nathan. Any other questions, please, at the end of this session, let us know.
Thank you so much, Glenn. That is excellent. I'm excited to hear about this. I believe it was Bill Gibson yesterday was sharing this with me. The name of the program, he said, was SAS. What does that stand for again?
Substance Abuse Solutions.
SAS, Substance Abuse Solutions, and it's through the Upper Cumberland Human Resource Agency.
Correct.
Excellent. And that's, I know Bill is in Putnam County,
Yes.
right? Putnam County. All right. Thank you so much. Look forward to the questions that will come for you and your opportunity to share more at the next session. Thank you, Glenn. Hang on. Right now, we're going to go to Josh Weil. And Josh is going to speak to us a little bit more about what he does. He's a regional opioid prevention specialist in Memphis. And I'm on the other end of the state, Josh, but I used to live in Memphis many, many years ago, about 30 years ago when my husband was in school there. So welcome today, and I look forward to hearing more about what all you're involved in.
Thank you. So it's actually regional overdose prevention specialist. And we primarily deal with distributing naloxone throughout the communities of Tennessee. Now, there are 22 of us across the state, so every county has access to a ropes. We have 2 here in Shelby County. The bigger counties have multiple ropes just due to the population. But we started this program in October of 2017. It's the Tennessee Department of Mental Health and Substance Abuse Services. It's a grant provided by them. And since October of 2017, we have distributed over 170,000 units of naloxone. We have 17,000 overdose reversals reported. Now, that's what we have reported, so that's not actually how many there is. In a lot of cases, the naloxone goes to the person, they disappear, and they don't contact us, but about 1 out of every 10 overdoses is fatal. So if you're looking at 17,000, that's a lot of lives that are saved. So the number is probably higher than that. The primary groups that we work with are first responders, and in our case, that mostly law enforcement. Here in Shelby County, we have 6 different police departments that we supply naloxone to, and they report back to the state through a database called the DI3. Individuals at high risk of overdose or their families or friends. So we do a lot of direct street outreach. We have events. We have the whole community here, recovery community, has kind of come together. We and the health department and treatment centers, for-profit and nonprofit, people that provide housing, the SOR Pathfinders, if you're not familiar with that, that's also under the Tennessee Department of Mental Health and Substance Abuse Services. We have a group of peer recovery specialists that have access to grants that pay for MAT, and that can get people directly into treatment. We work with the detox centers around here, and we have these events called stop events where everybody goes out to these high impact areas where there's a lot of overdoses, and we all set up tents and we feed people. We give out naloxone. Some cases we do syringe exchanges if we're authorized to do it in that area. And that has been very successful so far. We're trying to do that every 2 or 3 months in different areas based on the overdose maps. And we also do agencies and organizations that provide treatment and recovery services. And this is where integration comes in. So if you are a nonprofit treatment center, we can come in and train you as an agency. And as an agency, you can keep naloxone on the property and distribute it to your high-risk population. So anyone who is in direct contact with high-risk individuals, we want them to have Narcan, and say somebody has a positive drug screen or someone's leaving AMA and we know they're an opioid user, we want to be able to hand them a Narcan kit on their way out, so they have it close to them. And same thing with their friends and family. We work a lot with faith-based communities. When we do these events, we tend to kind of make the hub of that event a church in that community, and then that church is supplied with all the information they need to pass on to their congregation, and Narcan to pass on to their congregation if need be. And they kind of become a hub for that area for recovery. And they're called, I forget what it's called, but there's a program. It's a faith-based recovery church. And we kind of enlist churches around the areas to take on that role. And we provide them with resources for people in their congregation. So if there's a mother that is worried about her children or another family member, they can actually go to that church, talk to somebody, get some phone numbers, and get a naloxone kit. So, and we will train anyone. We've done about 1,500 trainings and trained about 32,000 people since 2017. And we focus on harm reduction, what it is. There's a lot of ideas about harm reduction that kind of tie in with stigma, as far, especially around SSPs and giving Narcan, that we're helping people to do drugs. And really the opposite is true. People that go to SSPs and people that are involved in harm reduction, trained in Narcan, are much, much more likely to get help. And we know that, but society as a whole does not. And then addressing stigma, of course, and we talk about the person first language and the science behind addiction, what's really going on. I heard Glenn say his son was given medication from a doctor and then took it continually. And then, now we have substance use disorder. Why is that? And why is it, looked at as a moral problem or a problem of weak will when it is absolutely a disease? They talk about the disease concept. Well, it's not a concept. We have about 75 years of research that shows exactly what's going on. And we're talking about things like genetic susceptibility and changes to the brain. And, I think that heavily relates to stigma, because people just don't know what they're looking at. When they're seeing someone with substance use disorder, they see the behavior, but they don't understand what's driving that behavior. And so we try to, spread that information. And, the reason, of course, that we exist, the Rogues, is because we have somebody dying about every 5 or 6 hours in Tennessee. Here in Shelby County, we've already had 155 fatal overdoses this year. And we are actually down from last year. The pandemic caused a huge increase in fatal overdoses. When the pandemic hit last year, we saw an increase of overdoses of about 65% in 1 month. And that was things like recovery meetings shutting down, access to treatment became harder, the stimulus checks. I heard stories over and over about people found out they had their stimulus, they left treatment, or, I would talk to a father who hadn't seen his daughter in 4 days because she got her stimulus money. So that definitely, it was kind of the perfect storm, a pandemic and an epidemic coming together, and it really, really exacerbated the opioid crisis. And I think as a whole, we were up last year about 10,000 fatal overdoses as a country. So, and we talk about barriers to our service, and I have to say that stigma is the biggest barrier that we face. So, we have hotels that have a lot of overdoses, things like that, and we go in the door to try to tell them what we're doing, and no, we don't have that problem here. When, we work with the organized crime unit, we know you have that problem. You had 2 last week, but they don't want to have anything to do with it. And then also, and this was mentioned a little earlier, the stigma around MAT. We have, because Narcan is harm reduction. It is a very, very small part of this. Everyone should have it. If you're dealing with high risk population, you absolutely should have it. But it is a very small part of the picture. We know somebody can't recover if they're not alive, right? So we try to keep them alive, but the main goal is to get them connected to treatment. And when we connect them to an SOR Pathfinder, they get put on Suboxone, and then they go to a halfway house, and the halfway house doesn't allow people that take MAT to stay there, then we have a problem, right? We are seeing it give way. Shelby County is a very abstinence-based recovery atmosphere, and that we have to see that change. The MAT is better. It's harm reduction. It may not be the perfect solution for everyone, but it's better, right? It's better than someone on the street chasing fentanyl and heroin. And we are starting to see some of those walls come down. Oxford House does allow someone with MAT if the House votes on it. And we have a couple more that have popped up that allow, like Harbor House is a treatment center that allows people on MAT in for treatment. And we are seeing more MARA meetings come up. But as far as for-profits using our services, although we cannot come in and train the agency and supply Narcan, you can absolutely refer your clients to the ropes for a one-on-one. We can train that person, determine whether or not they need a kit, and we can absolutely give it to them. And, we've done that a lot with MAT clinics, treatment centers. Anyone who is prescribed opioids should have Narcan. We can talk to them, break down the stigma about them going and using their Medicaid to get it from a pharmacy, or we can provide them with a kit. And I also have a lunch and learn, so we'll go into a little more detail about the program then. I don't want to take up too much time. I get going, I can't stop.
I understand. I think we're all like that. We're all very passionate about what we do. And thank you for sharing what you do, Josh. That's, as you can tell, affecting a lot of lives. What was the number you mentioned? You've trained 32,000 people.
Yeah.
And that's pretty amazing. And the stop events in your community, I'm really interested in that, especially in light of what we've been talking about with the hub and spoke model that Glenn was mentioning.
Yeah, we have a hub and spoke model here as well. That's how the SOR Pathfinders work. And it, of course, the hub is a treatment center, and the spokes are other treatment centers, but they work pretty well together. We've gotten to a point where we've got everyone talking to each other and referring to each other and things like that, and that's really what we want to see, is the recovery community working as one thing.
Right. Excellent. And I think what I have seen over the years that I've been working in this area is that every community is different. Every area is different. And what their hub may work out to be might be a different piece, in Upper Cumberland as a human resource agency being a hub, whereas the church or the treatment center in Shelby County, it might be a church in Northeast Tennessee that's the hub, or a medical center. So
absolutely. And you can't run Shelby County and somewhere in rural Tennessee the same way. You know what I mean? It's a completely different animal.
It very much is. Tennessee is an extremely diverse state, which is wonderful in so many ways, but it also means there's not always a cookie cutter solution for
Yeah.
every community, as we can see.
Yeah, and anyway, if any of you are not on the Lunch and Learn or at my Narcan training this afternoon, if you go to tn.gov and just put ROPS in the search, then a map will come up for Tennessee, and it will have the contact information, phone number, and email of the ropes that serves your area.
Excellent. If the three of you, Glenn, Josh, and Jason, if you wouldn't mind sharing in the chat box some of these connections and phone numbers and websites that you have, then Ron can take those and add those to our website, or you can send them to us later if that's easier, and we can make sure those get added for connection opportunities. At this point too, I do want to open it up. If anyone has any questions for these three men that you would like to have answered, just signal me, take yourself off mute. I see Bill, you're unmuted. Did you have a question?
It's not a question, but to Josh's point about this uptick, our police department carries Narcan, and they started it back in 2017. And last year, they started out maybe 6 administrations the first year, single dose. Last year, it was 30, it ticked up to 35. And so far this year, 18. Just in the first part of the year, and they're now seeing like 2 and 3 administrations to kind of get things turned around. So it's just like in the law enforcement realm, there's just an uptick in these overdose calls.
Yeah, and you know what? That's not just the pandemic. It's also, from what we're told by the local DA here, is that they're seeing a whole lot more fentanyl on the streets now. So that also is why it's taking more to get people out of it, because it's so strong, and now there's so much of it that, you know, we've got another thing thrown on the fire, that as far as the opioid crisis goes.
Right. I was just took my sons to the optometrist yesterday, and he was telling me how their office had been robbed. Some of the medication that they keep on hand there. Of course, he has people coming in all the time trying to get him to write prescriptions for specific drugs, which he has to turn down. He will prescribe an NSAID if needed, but he's just quit prescribing any others. But they do have some medications they keep in their office that, and this is in Northeast Tennessee, but a big, you know, gang operating out of North Carolina knew that they had these medications, and they came in and stole them from them. So things that are hitting the street are being used, you know, the fentanyl and other medications. People are manufacturing their own opioids, essentially, that they can't get prescribed. So the community awareness and education and the follow through and understanding these things through that trauma-informed lens of care is important in all realms, the clinical realm, and in the wraparound services in the community at large, understanding. So we've all got our work cut out for us in educating others for this. And along those lines, I would like to ask you three, what other gaps are you seeing? Are there anything specific that you're seeing in your communities that need to be addressed, or that are needs of patients that aren't being addressed right now?
Here in Shelby, I don't know about the rest of the state, we are very short on medical detox for the indigent population. So if you don't have insurance, we have a very limited supply of beds to get people into where we can, you know, get them to the point where they're ready to start Suboxone or go into some kind of treatment. So, you know, when someone's ready to go, they're ready to go. They might not be in an hour from now. And if we can't get them straight into a detox bed, which a lot of times we're dealing with, well, there's a waiting list. We can put their name on it, and then they're in the wind. So, you know, that's, from what I understand, there is another center being built. Alliance is expanding. Alliance Health Services is who does our detox for indigent here. But it's going to be a year or two, maybe, you know, building a new facility. So that's, you know, one of the things we run into quite a bit.
I know we've, just seeing through the pandemic, we had the scare of a shortage of beds that treatment centers were looking at for treatment of COVID possibly, and how so many came to the rescue with mobile clinics, even ships full of clinics. It's sad that it takes a pandemic and a scare like that to wake everyone up to the need that might be, but we're in the midst of another epidemic with the crisis of addiction. And there is a need, like you said, for beds. There's a need for distributing Narcan, overcoming the stigma toward
Yeah.
individuals.
We have social detox beds, but people don't stay in social detox is the problem. You know, one or 2 days without any medication for that withdrawal, and they're gone. And that's usually the case. That's what we see a lot.
Right.
They're more likely to stay if they're being given Subutex or something like that to, keep those symptoms down.
Keep them functional. Well, we've got to keep them alive first, right?
Correct.
And functional.
Yeah.
And then on to flourishing, right, Jason? I know that that's one of your goals, is keeping people functional and then flourishing in society. And Glenn, I know, Jason, you mentioned that transportation and housing were the big gaps that you're concerned with in the work that you're doing. And Glenn, are there any gaps that you all have identified in your region?
There can be gaps in every single stage. And so this is why it's important to have, I love Dr. Andy in the previous session was talking about multiple aspects of who a person is, the way that we were created. We're created as a physical, mental, spiritual, social, legal, emotional being. And so you've got to deal with all of those things. And if you're missing a gap in the services of any one of those areas, but yeah, the biggest gaps that all of us seem to be incurring right now is housing. Getting a person into transitional housing or into permanent housing is just almost impossible. So it's a struggle of where do you put them? How do you keep them in an environment to remain clean and sober when they have just come out of a treatment program? So this one of the areas that our agency has stepped forward into. We did not want to be filling the gap. We want to just bridge gaps, not fill the gaps. But we did receive a $900,000 grant from the Tennessee Housing Development Authority and through HUD for creating some emergency and transitional housing here in the Upper Cumberland. So we're beginning to we're in our first 30 days of getting that operational here to provide emergency housing for people. COVID has really affected that. A lot of the traditional places like the Mission that was typically always your go-to place for emergency housing. A lot of times they had to close down and not accept anyone into the Mission because of COVID, a COVID case that was discovered that they had to wait 1 or 2 or 3 days for a COVID test. So a lot of the continuum of care that was naturally in our environments has been terrifically disrupted by COVID. So we've been dealing with a very challenging time period.
Right, and being able to adjust to things like COVID and other things that happen in communities. It could be something like COVID, or it could be something just like a major industry shutting down and jobs being lost that can affect an entire community and send people into substance use disorders. And us being able to respond effectively and efficiently as a community, as that hub and spoke model, or whatever process we have in place, is so important. I wanted to just ask one last time if there are any questions. We're almost out of time. I have a list of questions that have been submitted, but I don't think we'll have time for all of them. We could maybe close up. I don't see anybody asking a question. Oh, I do. Wayne Smith, you have a question.
Well, I actually have 2 comments to make that I think are relative to the discussion we're having. Josh mentioned the district attorney in Memphis. Well, I've met with the district attorney here in Sumner County, and they started a promotion last year called Fentanyl, the Deadliest High. They have these little cards that they were handing out. And just to make mention of a dose of fentanyl that is equivalent to 4 grains of sand is a lethal dose. This is a nasty drug. Speaking from a perspective of a pharmacist, that which I have been for my whole life, fentanyl is a nasty, nasty drug. And the other thing I want to mention from the same kind of relation is the Narcan. Keep in mind, when you're handing the Narcan out, that it does have an expiration date on it, just like any other drug. In fact, mine, I carry one in my car at all times, just for emergency use. And it goes out of date next month. So you can actually turn those back in to someone like Josh, who is with ropes, and they can give you a replacement, and then they can utilize the one that's short dated in a hospital emergency setting so that it doesn't necessarily get wasted.
Yeah,
So
that's
those are
correct.
just 2 comments from a pharmacy perspective.
They do not allow us to redistribute expired Narcan, but the FDA has, it hit that milestone where now the expiration date has been extended for a year. So the ones we get now are generally, 2-3 years before they expire. And the protocol is just to throw them away, call us, and we absolutely will replace it with Narcan that is not expired.
Gotcha.
So the older Narcan is actually good for a year beyond the expiration date.
Okay, great. Thank you all for those comments and for the questions. I think we are at the end of our session, and as we dismiss, I wanted to just share one last comment with you in a quote. As we think about all the ways that we can address this issue as both coming around individuals and providing for their needs, and through our communities, through the hub and spoke models of treatment and how we're addressing it and what's being effective, connection is key. And so I want to close with this quote, and it's by Johann Hari. I'm sure many of you have heard of him and heard this quote. He wrote Chasing the Scream, the first and last days of the war on drugs. And he says, the opposite of addiction isn't sobriety, it's connection. It's all I can offer. It's all that will help you in the end. If you are alone, you cannot escape addiction. If you are loved, you have a chance. For 100 years, we've been singing war songs about addicts. All along, we should have been singing love songs to them. And so that's the challenge, I think, for us in our state. We are a state of musical beginnings and people. We love the idea of singing love songs to one another. And I think that's where we need to move going forward as we embrace these connections and build more connections with individuals overcoming stigma and within our communities and across the state. So with that, I want to thank you all for being here and invite you to the next sessions, which will be beginning right away. So the lunch and learns or exhibit hall sessions, you'll just go back to the dashboard and click on those, and we will see you there. Thank you.
Just leave that